Good evening. For those of you who are on the East Coast, and good afternoon to the many of you on the West Coast and wherever you are in between. What an amazing, amazing honor and privilege it is for me to be with you this evening. I am Liz Miller. I direct adolescent and young adult health at UPMC Children's Hospital of Pittsburgh, and am also the medical director of community health. And just incredibly delighted to be with you, to share with you some of the evolution of my own thinking as we work together to create a more equitable and just society for the young people with whom we have the privilege of working. So we have about an hour together. I see a number of folks are still coming into the room, so welcome to all of you. I see my dear friend, Rebecca Gudeman. Thank you for the invitation to be with you and to share some of my journey in this work, looking at the intersections of reproductive health and intimate partner violence and sexual violence and reproductive coercion. So I'm going to start, before I go into my slides, with a story. And thanks, Rebecca, with a story. And it's a story that some of you who are familiar with my work have probably heard me share it before. And really use that to anchor the work that we're going to talk about together. So it goes a little bit like this. So I actually have my PhD in anthropology, which I got while I was going through medical school, and was very interested in what we now call social determinants of health, or the social and structural influences on health, and was very fortunate to land in this doctoral program in anthropology. And it was there that I was actually introduced to critical theory and Black feminist scholarship, and really mind-blowing ways of thinking about how power shows up in relationships, how various social contexts impact the health and well-being of young people. So I did for my dissertation, for my doctoral dissertation, a study of HIV in Japan. This was in the early 90s. I'm a little bit old now, and ended up focusing my dissertation on the trafficking of adolescent girls from Southeast Asia, specifically Laos and Thailand and the Philippines, into Japan's sex industry. And at the time in the early 90s, we were completely sort of thinking in very separate domains. HIV transmission in one space, and gender-based violence in a very different space. And I ended up writing a dissertation about the critical importance of paying attention to gender-based violence and how this was underpinning the transmission of HIV globally. And was really, really intrigued by what a health professional like myself, a doctor who takes care of young people, what do I need to be thinking about and doing to better serve the young people in clinic and better recognize the violence that they were experiencing. And in the late 90s, I was so deeply involved in training health professionals about intimate partner violence and sexual violence and exploitation. And at the time in the 90s, it felt the one way to get health professionals to pay attention to what was going on in young people's lives, and frankly, in our patients' lives, was to screen for domestic violence and sexual violence and trafficking. And so spent a lot of time in my early years while I was finishing my training as a physician, obsessing about the right question to ask. Do you feel safe in your relationship? Are you afraid in your relationship? Has your partner ever hit you, kicked you, slapped you? Are you in a domestic violence relationship? Have you been abused? I suspect all of you on this call, right, have had similar kinds of screening questions perhaps asked of you when you had a primary care or an urgent care visit. And it felt at the time that screening was the right thing to do, because that was how we were going to kind of use the language of the healthcare system, use language that health professionals understood, and that we were going to really somehow be able to identify the cases. And so you fast forward to the year 2000. I have just finished all of my training, and I am a newly minted physician in a community health center. And I was working one night a week in a drop-in center for young people who are unhoused, unstably housed, and gang-affiliated young people. And at this clinic, a young 15-year-old female-identified young person came in for a pregnancy test. She did not want to be pregnant. She was not using any contraception, and her pregnancy test was negative. She looks, somewhat relieved. And I immediately sort of switched into reproductive health education mode. So I pulled out my beautiful laminated cards and started going through this in, detail, right? As many of you who do reproductive health education work do. And so I go through my contraceptive counseling. Along the way, I asked the adult domestic violence screening question, do you feel safe in your relationship? And she said, huh? And I said, well, can you get your boyfriend to use condoms? And she said, well, sometimes. And I handed her a brown bag full of condoms. And I said, it's so important to talk to your partner about using condoms every time. And when you're ready to decide what you would like to use for birth control, come back and see me. And 2 weeks later, I received a call from our emergency room saying, Dr. Miller, we think we have one of your patients here. This young person has sustained a severe head injury, having been pushed down the stairs by her boyfriend. And it was a just profoundly earth-shattering experience for me, certainly as a young physician, but also somebody who had done her doctorate on gender-based violence and HIV. And it was really that story and trying to understand what I had missed in that clinical visit that informs what we're going to talk about this evening. And in many ways, I have continued to dedicate my work to that young person with a deep sense, frankly, of regret for not thinking about the kinds of support that that young person needed, and really hoping that we can continue to do our work better. So with that, I am going to share my screen. See if I can. So where we're going this evening, and I changed the title just a little bit, and we will for certain talk about healing-centered approaches to address intimate partner violence and reproductive coercion and exploitation in this talk. But what I'm really hoping we can do more broadly, right? And this is a group of just incredible advocates in this room with me this evening. And I'm immensely grateful to you for the work that you do supporting our young people. And this is, I hope, a call for us to actually rethink the way in which we've been approaching trauma and violence, and hopefully put this and situate this talk, right, in what has been a very, very rich conference on reproductive health equity and where we need to move. So what are we going to talk about? We're going to talk about some of the dynamics of trauma and certainly the impact on health, but that's easy, right? Trauma and violence are bad for young people's health. Hard stop. But then I'm going to spend a fair amount of time talking about healing-centered strategies. And while the data that I'm going to share with you are clinic-based, I also want, for those of you who may not be working in clinical settings, but more community settings and other youth-serving organizations and school settings, that what we talk about, I hope, will be relevant for the work that you do. And that we start thinking about opportunities for prevention and how we may actually better address these health-related social needs in both our clinical and our community-based settings. So the very, very first piece that we need to cover is, Liz Miller, what do you mean by healing-centered approaches? What are we talking about? And certainly before any of us were talking about trauma-informed care, we spent a whole lot of time focusing on what's wrong with young people, right? And why are you behaving that way? What's wrong with you? And then with trauma-informed care, we became much more thoughtful and able to think about what might have happened to you that may help explain the kinds of behaviors that we're seeing. But where we're going to go with this paradigm shift is much more towards a healing-centered approach, which is, where do you want to go and how might I help you? Put another way, the problem with trauma-informed care is I worry that we've gotten too obsessed with being informed about the trauma. And I'm going to say a little bit more about that in a moment. But what healing-centered engagement is, in this, I am immensely grateful to Dr. Sean Ginwright for his work in this space on the future of healing. But it's really three key pieces, right? That healing happens in relationships, and that we have to, in all of the encounters that we have the privilege of having with young people, is to promote trust and connection. We also need to recognize that our children are not broken, our young people are not broken, our systems are broken, and we can actually focus our attention on assets, on strengths, on beauty, and specifically the agency and well-being of young people. But of course, right, to take this kind of approach is also explicitly political rather than clinical, because we are also broadening our gaze to include culture, spirituality, civic action, collective healing, the idea that we can actually build resilience by building community together. And while tonight I don't have all the time in the world, right, to talk about all of the different ways in which healing-centered approaches have been really transformational for the work that I get to do, I want to give you at least some examples of what this might look like in practice. But before we go any further, I also want to underscore that we need to position ourselves and recognize that in this space, there are many survivors among us. And for that, I am certain. Recognize that trauma is very prevalent. And as I go through this, just be really aware of your reactions. Please, please take care of yourself first. The stories are hard. What we're asking each other to do can be hard. And so just really immensely grateful for the survivors who are in the room, for the courage to be here and in conversation today. So my world really shifted in the last 4 to 5 years. Thank you to the incredible heroes in the movement, many who have come forward and talked about their experiences as survivors, shared their stories, and underscored the critical importance of centering survivor voices and experiences in our work. And this has really, truly been transformational in terms of being able to shift the kinds of conversations that we've been having around trauma and violence to one that is intentionally survivor-centered. But in addition, 2020 is a year that none of us will ever forget, although certainly the history of horrific traumas in our country continue to be stories that have to be told, and the stories about police brutality and just the horrific amounts of violence against Black and Brown people in this country. 2020 also was a moment when there was a tectonic shift for those of us who have been working in the trauma and violence field and pushing for a health equity lens, pushing for a social justice lens, that there was a significant shift where, for the first time in many of my talks with health professionals, I was able to start talking about undoing systemic racism, our obligation to bring anti-racist principles into our work, and to finally start to lay out the ways in which our systems have benefited from white supremacy culture. And of course, it saddens me deeply that we have lost so many people. And it is really my attempt to try to honor their memory in this work around shifting the conversation to healing and recovery. Because we all know that trauma looks very different and is distributed very differently across our society, from community violence and bullying, poverty and oppression. And of course, all of these affect health and well-being. My colleagues in Boston sort of put this diagram together to say, yes, as clinicians, we focus on individual traumas, but that is always nested within interpersonal relationships and trauma and collective trauma. And that we cannot take our eyes off of history and the critical importance of telling the history as a way to understand trauma and violence and the need for collective healing. So many of you, I suspect, are very familiar with the Adverse Childhood Experiences Study. And for those of you living and working in California, know very well that the healthcare delivery system has picked up on ACEs. And while so vitally important in terms of research to underscore the extent to which adverse experiences in childhood contribute to poor physical and mental health outcomes, that story is not the only story. Our colleagues in Philadelphia said, what about other adversities, from bullying to community violence, living in foster care, neighborhood safety, racism? So they called for an expanded ACEs. But I have to say, I just love the young people at the Rise Center who said, yeah, but let's not forget about history, shall we? And, with their work have really underscored historical trauma and undergirding any and all conversation around adverse childhood experiences, the critical need to give voice to race and experiences of racism, marginalization, and discrimination, and how trauma and violence is transmitted across generations, but that's not the sole story. because it is not only trauma and violence, right, that is transmitted across generations. It is also strength, beauty, hope, love, joy, and community. And that emphasis on resilience, that emphasis on the strengths that so many young people bring into spaces with them is really the key part for us in thinking about healing-centered engagement. So, yes, the violence is hard. I am sitting here this evening in Pittsburgh, having had a really rough week of losing several of my patients to gun violence. It has been horrific. Far too many of our young people are exposed to extraordinary levels of loss and trauma. And yet they lean in, they come into program, they're working with us on racial and gender justice. They're amazing youth leaders who are working to transform all of the environments in which they're in. This includes some of our middle schoolers who are part of our teen leadership work, who have recently started to work with colleagues from our School of Education to learn how to engage kindergartners and to read racially affirming and inclusive books to them. Young people give me a lot of joy. And I want to share that as we talk about healing-centered engagement and talk about trauma and violence and the impact on young people, that we also hold on to a term that I love, which is vicarious resilience. I suspect that each of you know what that means, because we stay in this work with young people because they're amazing. Their resilience, their strength, their beauty, their integrity, their joy is what fills my cup every day. And as we do this work of healing and recovery, as adult allies, as accomplices, as the professionals in their lives, we have to give voice to vicarious resilience and help each other in this work to lift up that vicarious resilience, which is what keeps us going. So, right, we do have a challenge though, because our systems are pretty darn steeped in white supremacy culture. And, we have a problem with silos. Although this is very funny. I was talking to young people about this recently, and they're like, Dr. Liz, what are those things? And I was like, they're silos. And we had a whole conversation about agriculture. But the idea, of course, is that there are people on this call who are working within the child welfare system, separate from housing, separate from the victim service agencies, separate from transportation, separate from the healthcare delivery system. And it is actually really difficult for us to do the work together. And in the interest of time, I'm not going to tell yet another story, but to underscore for us that our work is also about working across those and doing the beautiful work of cross-sector collaboration. And recognizing that one of the ways in which systemic racism shows up is actually by continuing to perpetuate the siloing. The ways in which funding is distributed goes by a particular health outcome, like the mental health funding or substance use funding, or something specific for housing that is not specifically connected to child welfare, and so on and so forth. Our work as advocates for young people has to be everything that we can do to strengthen our partnerships. We are always stronger together. So now I'm going to dig into, what does this mean practically, right? Liz, it's fabulous that you're thinking about healing-centered engagement and social justice and health equity, but really we're here to think about what does this mean in reproductive health practice. So where we're going to go, and I'm going to give you a little bit of background to this, is universal education, which means that we talk to all of our patients, in this case in clinical settings. But remember, I said, think about this even more broadly. The evidence base is in the clinical settings, but we can bring this out into other youth serving spaces. But talking to all young people about healthy relationships and offering resources regardless of disclosure. And to tell you that this approach is healing centered, it is equity based, and it is really framed as anti-oppression. And what do I, where are we going with this? So let's start with a little bit of the doom and gloom. So the doom and gloom is that far too many of our young people, and especially those who identify as female, experience a disproportionate burden of sexual violence and partner violence in this country. And I suspect that many of you saw the report from the Centers for Disease Control and Prevention early this week, kind of our first snapshot as we emerge from the COVID-19 pandemic, and the extent, of course, that young people were reporting depressive symptoms and suicidality. But I also hope that you saw the rise in sexual violence, both among young people who identify as LGBTQIA+, as well as female identified young people. And the challenge for us is the language that we use needs to continuously be informed by young people. And I'm going to take us back now 15 years when I first was really trying to understand what I had missed in that clinic visit in 2000. And I started interviewing young people about their experiences in abusive relationships. And one young person, and this is a tough quote to read, "I'm not going to say he raped me. He didn't use force," but I'd be like, "No." And then next thing, he pushes me to the bedroom. And I'm like, "I don't want to do anything." And then we ended up doing it. And I was crying like a baby, and he still did it. And then after that, he got up, took a shower, and I just stayed there, like shocked. And this kind of lack of control in sexual encounters, so many young people revealed in their stories in these very confidential interviews. And recognizing that a screening question like, have you ever been raped, or even forced to have sex, may not necessarily translate or be interpreted or perceived by a young person, because they have not necessarily labeled their experiences this way. And as I've worked with young people over the years, have really shifted my language towards making you do things sexual that you didn't want to do. And, continuously checking in with young people around if that is the right way to ask these questions. We also know that many of our young people communicate with each other across multiple social media platforms. And so certainly young people are exploring their sexuality online a lot, which means that many young people are also electronically sending each other nude and semi-nude photos, and helping young people understand that exploring their sexuality is one thing, and that there are real risks associated with transmitting photographs across social media, and helping young people develop those critical analytic skills so that they too can be in a place where they can at once be really thinking about their sexual identity and their relationships, but also have the boundaries and be learning about bodily autonomy as well. And we have plenty of work to do in this space. We need to work with young people, engage them in youth action research so that this work at once celebrates emerging identities and emerging sexuality and desire and pleasure at the same time that we equip young people with the skills to recognize what is and is not okay, what to do when boundaries have been crossed. So this is my one slide as the adolescent doc to say, it turns out we have lots and lots and lots of good research studies to say that sexual violence is bad for young people's health, whether it's unintended pregnancies, sexually transmitted infections, mental health disorders, substance use, and the like. So we know, right, this is really a healthcare issue. So I told you at the beginning that in the 1990s, right, I was super gung-ho. We're going to screen everybody. We're going to ask them, do you feel afraid in your relationship? Do you feel safe in your relationship? So in the chat for me, please share, why might a young person, especially a young person who's unhoused or a young person who is queer, not want to disclose violence or exploitation they may be experiencing? What are reasons that they might not want to share their story with us? Afraid of being outed by their abuser. They know it'll be reported. Absolutely. Other reasons that a young person might not want to disclose. Not wanting to admit that they're victims. And certainly picking up on the knowing that they'll be reported. Absolutely, thank you. Documentation status. Distrust, right, of government workers, don't want to get involved with child protective services, law enforcement, the fear they won't be believed, certainly not being believed, right? All that shame, the humiliation, being, quite certain that we will judge them. If their parents, absolutely fear their children being taken away, right? There are many, many reasons that our young people don't necessarily want to trust us with their stories. So it is that understanding of when we're thinking about survivor-centered care, and Anne-Marie, thank you, not aware that this is even abuse, right? Just normalizing the trauma, absolutely. And certainly could be in, environments, right, in which they have witnessed adult caregivers hurting each other as well. So, it's just amazing to me as we see how quickly you all came up with that and how embarrassed I am that as I was embarking on my career as somebody who thought I knew what I needed to know about violence and trauma and that we were going to screen for this. I'm really sorry because that was not the right paradigm. And it is not the right paradigm for ACEs. It's not the right paradigm for partner violence. Certainly not the right paradigm for trafficking and exploitation for the multitude of reasons that you all have outlined. Because when we focus on disclosure-driven practice, those of us, like me, in positions of power and privilege, hold all the resources. And if you're a good young person and you tell me the truth and you share your story with me, then I will connect you to resources and support. You see how problematic this is and why a screening paradigm, a disclosure-driven practice, is in fact steeped in white supremacy culture, steeped in institutional racism, and contributes to the perpetuation of inequitable distribution of resources. We can do our work differently. So one example of this is taking a more universal education approach. I have never had a patient waltz into my office or clinic and say, "Hi, Dr. Liz, I'm in an abusive relationship and I need help." Right? Very few adolescents were going to report their experiences of violence to adults. And yet we know there is a tremendously high prevalence of relationship abuse and sexual violence, certainly in clinical settings, but in many of the other settings in which you all work. And what happens then if our goal shifts to education about sexual and partner violence and underscoring that this setting is a safe place to talk about these things? So first, let's think about providing universal education. And I'm going to get you to sort of the data showing that this is in fact a research-informed approach. Very easy mnemonic to remember, which is cues. C for talk about the limits of confidentiality, U for universal education, E for empowerment. I'm sharing this information with you because I suspect you have a friend that you could help, right? And we'll get to that in a moment. And then the S for knowing how to make a warm referral. When a young person does choose to share their story with us, that we treat that as the incredible gift that it is, and that we know who the counselor is on the other end of the phone line. We know who to call at the Victim Service Agency. Perhaps we even have an advocate embedded in our setting. There are ways in which cross-sector collaboration makes a difference when we can better support young people by actually creating a team that surrounds young people. So, of course, the limits of confidentiality, and depending on what state you are and how you're going to talk about this, is going to vary. But even when we're doing universal education and not direct inquiry, right, we're not specifically asking somebody to disclose, young people will share, right, when you start to create safe spaces. So it is always, always important to remind them what the limits are. But I hope that none of you ever use the word report with our encounters with young people, because the word report translates to judgment, it translates to fear, it translates to you are in trouble, right? As opposed to, I need to bring other adults into this conversation to help increase your safety. And while our systems are imperfect, so is our language. And I hope that over the next decade that you will join me in a national movement to shift from mandatory reporting to mandatory supporting. So as part of this work around universal education, with lots of input from young people, including young people who were system involved, we designed an educational safety card around adolescent relationship abuse. And it's so simple, right? These are palm size, and let me grab one. They're palm size safety cards. You can see them here on, in front of my face, and are fold out to have lots of just information, lots of information about healthy and unhealthy relationships, and provides an amazing opportunity to provide primary prevention. Because as you noted in the chat, some young people may not even recognize what they're experiencing as being abusive or coercive. Certainly educating our young people about what they can do if they have a friend or family member who may be struggling with abuse, and plants the seeds for young people experiencing abuse but are not quite ready to disclose, and introduces survivors to options for safety, harm reduction strategies, and support services. So while I was actually living in California, had the immense privilege of partnering with the California School-Based Health Alliance and a number of our school health centers across the state of California. And we actually tested this approach in school health centers, half of them getting this universal education training and approach, and half doing business as usual. And lo and behold, what did we find? In the clinics receiving this cues intervention, there was increased recognition of what constitutes abusive behavior and sexual coercion, increased awareness of adolescent relationship abuse, it's ARA resources, And among young people with recent exposure to violence, we were not expecting to actually shift violence outcomes with a brief intervention like this. And yet, with adolescents, we actually found 3 months later, far fewer young people reporting relationship abuse in the intervention clinics. And then here I am saying disclosure is not the goal. Move away from this emphasis on extracting stories from young people. That is not the goal. And yet when you create a space where you're like, we're talking to all young people about this, what happens is young people feel a little safer. They feel like they can trust, and young people will lean in and start sharing stories. And that's certainly what we found in this study. We have also done this work with women's health clinics, family planning clinics. Some of my earliest work also in California was with our family planning clinics, including Planned Parenthood in Northern California. And I'm immensely grateful to them because it was working with survivors and with providers on the front lines that we were actually really able to design an intervention that would make sense. And again, brief universal education. What do we know about family planning clinics? Taking care of some young people who are really made vulnerable through so many social and structural factors, and immensely grateful to them for the work they do. Because over half of the young people, these were young people ages 16 to 29, seeking care in family planning, women's health clinics, over half reporting a lifetime experience of physical or sexual violence, about 18% reporting this in the past 3 months. And what we identified early on in this study were ways in which partners were using reproductive health as a mechanism for control. He used condoms when we first started, then he'd fight with me over it, and he just stopped using condoms completely, didn't care. He got me pregnant on purpose, and then he wanted me to get an abortion. We interviewed a lot of young people and over and over and over again heard these experiences of reproductive coercion and sexual coercion. Replicated that interview study with adults, all survivors of intimate partner violence, and these stories of reproductive coercion and sexual coercion continue to emerge. These include explicit attempts to impregnate a partner against her wishes, controlling the outcomes of a pregnancy, whether forcing a termination or forcing a continuation of a pregnancy that was not wanted, coercing a partner to have unprotected sex, and this can certainly include removing condoms, what is often called stealthing in the midst of intercourse, and interfering with birth control methods. And that interference with birth control methods can be intensely physical. This can be removing birth control patches, flushing birth control pills down the toilet. And everybody take a deep breath, right? Pulling out IUDs. So what did we find in our work? That in the clinical setting, about 25% of women reporting having ever experienced reproductive coercion. And in our work in the school-based health centers too, in the past 3 months, right, over 500 girls in this sample, 12%, past 3 months, 12% reporting experiences of reproductive coercion. And similarly high prevalence of physical and sexual relationship abuse, as well as sexual violence from some person using violence, right? A perpetrator, somebody that they did not consider to be a partner. And what do we know in the clinical setting about how this shows up? Remember that I opened with a story about a 15-year-old young person who's like, I don't want to be pregnant, but I need a pregnancy test. I'm not using any birth control. Don't want to be pregnant. And it didn't occur to me to connect the dots at the time because I didn't even have the language to say what you may be experiencing is reproductive coercion. it clearly, it was staring me in the face, and I didn't recognize it as a clinician. And so for those clinicians in the room, think about STI test, the young person who keeps coming in for sexually transmitted infection testing and treatment, or that, recognizing that some young people will choose to use a hormonal method, but not be able to actually negotiate condom use with a partner. And, my goodness, 23 years ago, I sat in that exam room with that young person, handed her a brown bag full of condoms and said, be sure you talk to your boyfriend about using condoms every time. I feel so, I share this with you, right? To say that we can actually learn from things that we've missed. We can continue to evolve as clinicians to better serve our young people, and to be much more attuned to how hard it is for young people to actually negotiate condom use, whether it's in, regardless, right, of same-sex relationships, and the range of sexual relationships, that it is so difficult when we don't equip young people with the scripts to talk about condoms and to be able to manage those boundaries. We have to do a better job in our comprehensive sexual health education. So as part of our work in the reproductive health setting, we designed another educational safety card. We evaluated this because this is what I do as a researcher, right? But what we included in this intervention was more training for the clinicians around harm reduction, because there's a lot that clinicians can offer for birth control that their partner doesn't have to know about. In fact, one of my patients taught me the possibility of cutting IUD strings. Her husband was actually monitoring her periods, and so she did not want to be on a hormonal method. And we opted for the copper IUD. And she said, Dr. Liz, I'm afraid he's going to feel the strings. She said, could you cut the strings? So first time they placed a Paragard with cut strings. Harm reduction, meeting our patients where they're at, making sure that they have emergency contraception. I have them take it out of the box and fold it up into, roll the emergency contraception into a little piece of paper and have it stored in a place, right, that they have easy access to. Helping our young people talk to their partners about the need for treatment for a sexually transmitted infection, or perhaps maybe it's too scary to do that. And as a clinician, as part of a harm reduction strategy, I have also pretended to be the health department calling from a neighboring county, so that the young person does not have to be the one who is telling their partner about an infection. Meeting our patients where they're at, meeting young people where they're at, and really thinking about safety first. That's what we get to do. And getting back to our cross-sector collaboration, we have to have the skills to be able to connect with, partner with the phenomenal victim service advocates who have taught me so much. We can have annotated referral lists, and this is in our clinics, but also in our youth serving agencies. We need to know each other. We need to know each other on a first name basis, the languages that are spoken. How do we get there? What's the transportation look like, etc. And we can educate our clients and all that our clinics, our youth serving agencies are safe places for them to connect to these resources. And what have we found? Actually, this brief intervention makes a difference. We're able to reduce reproductive coercion. We've replicated this work in family planning clinics out here in Pennsylvania, found increased knowledge of resources, increased self-efficacy to use harm reduction strategies. And for those women experiencing high levels of reproductive coercion, we were able to actually find reduction in reproductive coercion a year later. And what is so interesting about doing this work is that there is this epiphany as this one provider described, she said, we just didn't make the connection between women who were perpetually late coming in for their depot shots, women who kept calling saying they lost a pack of pills, or coming in 3 months late to refill their pills, and really reframing our thinking on various obstacles in women's lives and how they're affecting their reproductive choices. And, for those of you working with young people day in and day out, and how often we go to that place of, can't you remember to take your pill? And that we maybe need to pause and actually think about what some of those obstacles might be. And from the young person's perspective, they say they'd bring out a card, basically walk in with it. She'd open it, she, meaning the clinician, opened it and asked me, had I ever seen it before? It was awesome. She'd touch on having, no matter what the situation you're in, there's something or some place that can help you. I don't have to be alone in it. That was really huge for me because I was alone most of the time for the worst part. And imagine if we reframe, right, from screening and disclosure and case identification, leave that aside and offer universal education and connection, that what we are really striving to do is increase options for safety and to reduce that sense of isolation and shame. And how beautiful is that? And then that share this information with people you know. And this young person said, getting the card makes me actually feel like I have a lot of power to help somebody. So I'm going to leave you with the thought that healing-centered engagement is in fact anti-racist practice, and that we can continue to push back on this emphasis on extracting stories of trauma and screening for trauma, and put that aside and recognize that we have an incredibly important role in supporting healing and recovery for young people. And I share with you the National Health Resource Center on Domestic Violence. These are your taxpayer dollars at work. Futures Without Violence produces beautiful material to support providers, advocates, frontline workers with free educational resources. So please reach out to them. And I thank you for the gift of your time. And I've left a little bit of time for questions. Or maybe even a reflection in the chat. Yes, thank you. The safety card is from Futures Without Violence. Oh, Rebecca, thank you for sharing that story. If I remember right, maybe it was this story or another related story about where the young person was told, can't you keep your legs crossed?
Oh, yes, I'd blocked that part out. Yes, I'm extremely grateful to you for coming in and sharing some of the knowledge you just shared with the court. It was incredibly painful to have these people who are in the lives of young people and making decisions about their lives make this kind of lighthearted jokes about someone who was in crisis.
Indeed, indeed.
Liz, I'm wondering if you, given the current political landscape with so many states now restricting access to different kinds of sexual and reproductive health care, do you have a sense whether this might influence either people's willingness to report reproductive coercion or violence, or the actual prevalence of violence or coercion?
So all of the above, right? I think that the more that we restrict access, right, and access to sexual and reproductive health care, including access to comprehensive sexual health education in schools, right? That how we get this information to young people and how we help them navigate what is a really complicated landscape on social media. And you heard me say, you know, young people are exploring their sexuality. They're exploring their sexuality online. That, of course, includes engaging with sexually explicit material online. All of that part of normal adolescent development. And yet at the same time, we're missing so many opportunities to really help young people develop those critical skills to say, this feels okay, this doesn't, this gives me pleasure, this does not, right? And certainly the impact of the COVID-19 pandemic does not help, right? The level of social isolation, the level of disruption in connection, but also the disruption of the just being able to have access to sexual and reproductive health and prevention education. So you add now the layers of complexity in states that are restricting access to care. And we have to be really clever. We have to think about, you know, where can I work with the folks around Plan B and ulipristal around emergency contraception dispensing and make sure that information about sexual violence and exploitation is on the packaging so that we get some information out. You know, I think that there are really important ways as advocates working with young people that we have to think about how we're going to ensure that they have access to medically accurate information and care. So here's a skills question around how do we state that we're mandated reporters to young people in a more supportive way? And I'll try to answer this briefly. So my script is something along the lines of, I'm so grateful that you came in today. And before we get started, I want to share with you how this clinic works, right? We really, really value your privacy, your safety, and your confidentiality. And I also want you to know that in this clinic, we are also really big on protecting young people. And if a young person comes in and shares with me that they are at risk of hurting themselves or of hurting somebody else, or somebody's actually hurting them, there are some times that we have to bring other adults in to help keep that young person safe. So I really emphasize safety, never use the word reporting. But the other piece that I do is that when a young person has chosen to disclose a story with me, I thank them for their time, you know, for just the incredible gift of trusting me with their story. And I also validate, right, and say this, nobody deserves to experience what you've experienced. And remember when we talked at the very beginning about your safety, this is one of those instances. But one of the things that I really encourage us to do more is when we do need to file with Child Protective Services, that we actually do that with a young person in the room with us. It's called client-centered reporting. I'm going to put my email in so that we are so that you can contact me and we can actually talk about some more training around client-centered reporting. I think it is critically important that if we are going to involve Child Protective Services, that the young person be actually part of doing that filing together. And that's my email in the chat. And Elaine, I see your comment about the ways in which our healthcare delivery system is structured, and I can't underscore that enough. Yes. And we do need to actually shift towards more value-based care as well.
Well, I think that's it. Thank you so much, Liz Miller. It's always amazing to hear from you. Thank you to everyone in the
Oh,
audience for
goodness.
sticking through. And we're grateful to everyone for being part of the day. And yeah, we'll listen to you anytime, Dr. Miller.
Oh, you all are the best. Thank you, each and every one of you, for the work that you do every day. Thank you for all the learning you did together today around reproductive health equity. Rebecca, thank you for your leadership in this space. I just appreciate you so much.
Right back at you.
Yeah.
All right. Have a good evening, everyone.
Take care, everyone.